Hello, everyone. Kara McKee and I, Chris Mahoney, will be presenting on fractures and compartment syndrome. Some disease background and the definition of fractures. Um, fractures are a break or a disruption in the continuity of bone. There are several different types of fractures. There are closed fractures, so there's no break in the skin over the fracture. There are open fractures, so that's when varying amount of skin or soft tissue um, is exposed over the fracture. There are incomplete or complete fractures, simple or comminuted fractures, traumatic or pathologic fractures. So that would be an example of a pathologic fracture. It would be like a multiple myeloma patient who has a fracture. Intra-articular or extra-articular, so in the joint or outside of the joint. Displaced or non-displaced, avulsion, buckle, stress. And then the fracture lines, there are different terms for the fracture lines. You have transverse, spiral, oblique, comminuted, longitudinal, butterfly, segmental, impacted, or stellate fractures.
Here are two charts describing the different types of fracture. For typical complete fracture, you have closed, which is a non-communicating wound between bone and skin. Open, which is a communicating wound between bone and skin. Comminuted, which involves multiple bone fragments. Linear, which is a fracture line parallel to the long axis of the bone. Oblique, which is a fracture line at an angle to the long axis of the bone. Spiral, which is a fracture line encircling the bone, such as a spiral staircase. Transverse, which is a fracture line perpendicular to the long axis of the bone. Impacted, which involves fracture fragments pushed into each other. Avulsion, which involves fragment of the bone connected to a ligament or tendon that detaches from the main bone. Compression, which is a fracture wedged or squeezed together on one side of the bone. Displaced, which is a fracture with one, both, or all fragments out of normal alignment. Extracapsular is a fragment close to the joint but remains outside of the joint capsule. Intracapsular is a fragment within the joint capsule. For typical incomplete fractures, you have green stick fractures, which is a break in one cortex of the bone with splintering of inner bone surface. It commonly occurs in children and the elderly. There is torus, which is buckling of the cortex, bowing, which is bending of the bone, stress, which is microfracture, and then you have transchondral, which is a separation of the cartilaginous joint surfaces or articular cartilage from the main shaft of the bone. Here you can see illustrations of the different types of fractures, such as closed, open, transverse, spiral, comminuted, impacted, green stick, and oblique. For the pathophysiology of fractures, it involves the etiology factors, which will be discussed in the upcoming slides, plus a force applied that exceeds the tensile or compressive strength of the bone, and this results in a break in continuity of a bone. For additional pathophysiology of a fracture, when a fracture occurs, the periosteum and blood vessels are disrupted. Bleeding occurs from the damaged end of the bone and neighboring soft tissue. Then a hematoma forms within the medullary canal between fractured ends of bone and beneath the periosteum. Bone tissue immediately adjacent to the fracture dies, which stimulates vasodilation, exudation of plasma and leukocytes, and infiltration by inflammatory leukocytes, growth factors, and mast cells decalcify fractured bone ends. The vascular tissue from surrounding soft tissue and the marrow cavity invades the fracture area. Blood flow to the entire bone increases, and bone-forming cells in the periosteum, endosteum, and marrow are activated. This produces subperiosteal procallus along the outer surface of the shaft and over the broken ends of the bone. Osteoblasts within the procallus synthesize collagen and matrix, and this becomes mineralized to form callus. The repair process and remodeling continues, and unnecessary callus is resorbed. Trabeculi are formed along lines of stress as repair tissues align with the tissue cells of the host. For the etiology and predisposing factors of fractures, it involves high energy trauma such as crush, blunt, and deceleration forces, rotational forces, metabolic disorders such as Paget's disease, rickets, and renal osteodystrophy, osteoporosis, osteopenia, tumors of the bone such as primary and metastatic, drugs such as corticosteroids and phenytoin, nutritional deficiencies such as vitamin D, malabsorption syndromes, inflammatory bowel disease, and alcoholism, infectious disorders such as tuberculosis and osteomyelitis, congenital disorders, and neuromuscular disorders such as spinal cord injury and muscular dystrophy. For the risk factors of fractures, you will see a lot of overlap with the etiology. The risk factors include low bone mineral density, advancing age, fall risk, women, prior history of fragility fractures, chronic disease such as rheumatoid arthritis, nutritional and gastrointestinal problems, chronic obstructive pulmonary disease and asthma, endocrine disorders, immobility, chronic kidney disease, HIV/AIDS, cancers including prostate and breast cancer, hematological disorders, and psychophysiological disorders and mental illness, excessive alcohol intake, cigarette smoking, parental history of hip fractures, low body mass index, menopause or hysterectomy, poor nutrition and low dietary calcium intake, vitamin D deficiency, inactivity, and medications such as long-term glucocorticoid therapy, certain steroid hormones, proton pump inhibitors, certain medications to treat diabetes, certain antidepressants, anxiolytics, sedatives and neuroleptics, certain immunosuppressants, thyroid hormone treatment, aromatase inhibitors, certain chemotherapy agents, certain antipsychotics, certain anticonvulsants and antiepileptics, and anticoagulants. For the clinical manifestations of fractures, the subjective data includes unnatural alignment or deformity, swelling, muscle spasm, tenderness, pain, impaired sensation, decreased mobility, headache, and a history of a traumatic event or other precipitating factors. For the objective data of fractures, this includes pain with palpation over the fracture site, deformity of the limb, palpable and audible crepitation, diminished or absent distal pulses, swelling, ecchymosis, decreased range of motion, limited mobility or weight bearing, neurological injury distal to the fracture, and broken skin with or without bone protrusion. Here are symptoms based on the location of the fracture. For the cervical spine, you may see an abnormal neurological exam, abnormal respiratory function, facial trauma, or decreased or absent rectal tone. For the shoulder, you may see an inability to abduct or adduct the arm. For the humerus at the proximal site, you may see ecchymosis, deformity, or inability to abduct the arm. At the midshaft, you could see neurovascular compromise, radial nerve palsy, or abnormal positioning. At the distal site, you may see neurovascular compromise or the inability to flex or extend the elbow. For the forearm, at the proximal site, you may see swelling or the inability to flex or extend the elbow. At the midshaft, you may see swelling or tenderness on pronation or supination. At the distal site, you may see a deformity around the wrist or the inability to flex or extend the wrist. For the wrist, you may see a dinner fork deformity or the inability to flex or extend the wrist. For the hand or finger, you may see pain or they may have obvious deformity. For the hip or proximal femur, you can see shortening with external rotation of the leg. For the femur at the midshaft and distal site, you can see shortening with internal or external rotation of the leg. For the tibia at the proximal site, you can see a plateau fracture with swelling, or it could be a colt. At the midshaft, there could be swelling, or you may see exposed bone or a laceration. At the distal site, you can see external or internal rotation of the foot. For the ankle, you may see malposition of the foot, ecchymosis or swelling. For the foot or toe, you may see ecchymosis or swelling. For thoracic or lumbar, you can see pain, bowel or bladder dysfunction, numbness, tingling, or weakness. For the pelvis, you may see leg shortening, perineal ecchymosis, swelling, and bleeding. For laboratory studies, you will want to collect a complete blood count, and you may see leukocytosis without a left shift, and this is usually a stress response to trauma. If there is bleeding, you will want to do serial hemoglobin and hematocrits. You'll want to collect a urinalysis. You may see myoglobinuria with crush injuries, and then blood with acute blunt or penetrating trauma. You will want to collect a basic metabolic panel or a complete metabolic panel, serum lactate, creatinine kinase, coagulation studies, and a type-in screen. For diagnostic studies, you will want to obtain an X-ray, including anterior, posterior, or AP, and lateral films, oblique films for complex fractures of humerus, femur, or ankle, Mortise view of ankle fractures, and swimmer's open mouth views of odontoid. You will want to obtain three-dimensional and or coronal and sagittal CT scans of the pelvic or spinal fractures that were found on plain films, and inlet and outlet views of the pelvis. You can also obtain an MRI with a spinal cord injury. Other diagnostic studies includes a DEXA scan, continuous electrocardiography monitoring for crush injuries, and an arteriogram or Doppler ultrasound. This slide covers the Gastillo classification of open fractures. For type 1, the wound is less than 1 centimeter and has minimal contamination. For type 2, the wound is greater than 1 centimeter, has moderate contamination, and no extensive soft tissue damage with bony comminution. For type 3, it is a high degree of contamination. It is a severe fracture with instability, and it has extensive soft tissue damage. For type 3A, the soft tissue coverage is adequate, but the fracture is severely comminuted. For type 3B, it is an extensive injury to soft tissue and moderate amount of periosteal stripping with exposed bone. For type 3C, it is an open fracture associated with arterial injury, and it is not dependent on the amount of skin or tissue loss.
Next, we'll talk about the pharmacological management of these patients. So if the patient has suffered an acute injury and they need to be fluid resuscitated, you can use NS or LR. The patient may also require a blood transfusion. However, if the patient has suffered a crush injury, then you want to avoid LR because LR contains potassium, and patients with crush injuries, their muscles are injured and being affected, so their K could increase. Additionally, a lot of these patients go into renal failure, so if you can avoid contributing to the high potassium, then that's obviously better. Patients with open fractures may require antibiotic coverage. So if it's a grade 1 or grade 2 fracture, then they'll need gram-positive coverage. This can be done with a cephalosporin. Barkley mentioned cefalozin, 2 grams if the patient is less than 120 kilos, and 3 grams if the patient is greater than 120 kilos. IV every 8 hours for 3 days. And if the patient has a penicillin allergy, then you can use clindamycin 900 milligrams IV Q8. If the patient has sustained a grade 3 fracture, then they need gram-negative and gram-positive coverage. So you can use cefoxitin 2 grams IV Q8, cefotitan 2 grams IV Q8, or ampicillin sulbactam 3 grams IV Q8. If MRSA or MRSA rather is suspected in the patient, then you can also add vancomycin, and then obviously they just need their vanc trough. If you need anaerobic coverage, then clindamycin 600 milligrams IV Q8 can be used. And if it's unknown whether the patient has received their tetanus shot, then they may need a tetanus toxoid if their status is unknown. Pain management is also very important in these patients. So if the patient needs IV pain medicine and they need it pretty frequently, then they can be put on a PCA pump. Some of the medications used on these PCA pumps include morphine, so that can be 1 to 3 milligrams every 8 to 15 minutes, fentanyl, 10 to 25 mics every 8 to 15 minutes, Dilaudid, zero point 0.6, excuse me, zero point 0.1 to zero point 0.6 milligrams every 8 to 15 minutes. And then if the patient doesn't need frequent pain medication like that, and they can tolerate PO meds, then you can give medications orally. Some common ones are the oxycodone acetaminophen. So for mild pain, you can use 5 milligrams of oxycodone to 325 milligrams of acetaminophen. And if the patient, has moderate to severe pain, then you can increase it to 7.5 milligrams of oxycodone and 500 milligrams of Tylenol. And then we also have the codeine acetaminophen. So the dosage for this, if the pain is mild, would be 30 to 325 milligrams. And then moderate to severe would be 60 to 325 milligrams. And then we have the hydrocodone acetaminophen, which is 5 to 325. And then for moderate to severe pain, it's 10 to 325. And then multimodal pain control is also very important. So some multimodals that can be added include NSAIDs, acetaminophen, gabapentin, or sometimes peripheral nerve blocks will be used. Next, we'll talk about non-pharmacological management for these patients. So acute management will include trauma care. So part of trauma care will include like your ABCs, so airway, breathing, circulation, and just monitoring and making sure the patient is safe. The musculoskeletal examination is part of the secondary survey, which is also part of trauma care. You'll want to monitor coags, especially if the patient needs to be resuscitated, fluid resuscitated, because of hemodilution. You want to cover open wounds with saline dressings. So if the patient comes in with an open fracture, you want to use a saline dressing until they're able to go to the OR. And then they'll need surgical irrigation and debridement within 6 to 24 hours. And oftentimes a wound vac will be used with severe open wounds. You also want to immobilize the fracture or the break. Um, they called it reduction of the fracture. So you can do this with splinting, internal or external fixation. You'll then want to get x-rays. You'll want to do neurovascular checks to make sure the extremity is perfusing. If you have a closed femoral or tibial shaft fracture, then you may see intramedullary rotting. So that's when they'll go to the OR and they'll place essentially a rod through the femur or the tibia. External fixation will also require soft tissue care once it's done. And severe crush syndrome, it may require renal replacement therapy if the patient goes into renal failure. And then here I just have some visuals of what internal fixation and external fixation looks like. So in the figure above, that's internal fixation. So things like using plates or rods or screws. And then you have below, you have your external fixation. So it's like these devices used on the outside. Your interprofessional collaboration for fracture patients will include sometimes the ER physician, right? If they're acute, they'll come in through the ER and the ER team will manage the patient, and then they'll hand off, if needed, they'll hand off to ortho, and then ortho becomes involved. If the patient has sustained a crush injury and goes into renal failure, then maybe nephrology will need to be involved. Obviously, PTOT will need to be involved at some point. Pain services, acute pain management may need to be there. If the patient, has pathological fractures, then potentially chronic pain management will need to be part of the team. And then wound care may be required if the patient has an open fracture or If they have external fixation, then wound care may need to be on board. Some geriatric considerations for patients with fractures. It's important to note that osteoporosis is a common cause, so the patient may need to be started on medications before they discharge. So this would include like calcium supplements. If the patient needs to go home on a bisphosphonate, then there needs to be further discussion because bisphosphonates have osteoclast activity, which could actually worsen a fracture. And then another common cause for fractures in the elderly are falls. So falls can lead to long-term disability as well as death. And some common causes for falls include sarcopenia, sensory loss, unsafe footwear, medications. So polypharmacy is a culprit, and cognitive impairments. So oftentimes these patients suffer from dementia. So it's important for them to have a safe home environment. So that's another thing that should be considered before the patient discharges is like an evaluation of their home environment and making sure that there aren't random cords laying around, the rugs are put down, things of that nature. So now we'll move on to compartment syndrome. Some disease background and definitions of compartment syndrome. Compartment syndrome is increased tissue pressure within a limited space, and then that compromises the circulation and function of the contents within that space. So a compartment consists of bone, vessels, nerves, muscle, and soft tissue lying within the fascial envelope. And the fascia is a non-expanding tissue, which further contributes to the problem. 38 out of 46 compartments are in the arms and the legs, and it can also occur in the abdomen, in the abdominal muscle compartments in trauma and or surgical patients.
The pathophysiology of compartment syndrome is a cycle that begins when there is an increase in compartment volume and external restriction of compartment size. This leads to an increase in compartment pressure, which decreases arterial pressure and increases venous pressure. This leads to capillary bed collapse, and there is a decrease in tissue perfusion. There's also an increase in capillary permeability and worsening edema, and this ultimately leads to tissue death. The etiology of compartment syndrome involves a space-limiting envelope, such as circumferential dressings, casts, splints, or burns with eschar or scars. Increase intracompartmental contents, such as bleeding, hemorrhage, or coagulation disorders. Iatrogenic, such as infiltrated intravenous sites, improper positioning, especially with the lithotomy position, or arterial blood gas punctures, venous pooling or obstruction, such as patients found down for an unknown period of time, or rhabdomyolysis, and increased capillary filtration, such as trauma or surgery, crush syndrome, tissue ischemia, reperfusion injuries, thermal or electrical burns, snake or spider bites, intermittent swelling and fluid shifts during exercise, or overfluid administration. Risk factors for compartment syndrome really involves any condition that increases the volume of the compartment without an increase in the diameter of the unyielding myofascial envelope. Other factors includes males, usually less than 35 years, coagulation disorders, improperly placed casts or splints or tight circumferential bandages, soft tissue injuries or infection, traumatic injuries such as fractures, specifically long bone fractures, including tibial fractures, crush injuries, burn injury, bite and stings, high pressure injection, or birth injury. Also, extremity ischemia, reperfusion injury, spontaneous hemorrhage or hematoma, prolonged extremity immobilization, deep venous thrombosis, non-traumatic muscle injury, extravasation injury, drug overdoses, intra-arterial injection, SIRS with massive fluid resuscitation, intense athletic activity, poor positioning during surgery, and cirrhosis. For the clinical manifestations of compartment syndrome, the subjective findings include pain out of proportion to the injury, a history of trauma, a history of being found down from intoxication or drug overdose, paresthesias such as decreased sensation in the affected limb, heaviness in the affected extremity, muscle weakness, and the patient may complain that their skin feels too small for their leg. For compartment syndrome, the physical examination findings include pain on passive stretch of the affected compartment, paresthesias along dermatomal patterns with loss or diminished sensation in the affected areas, paralysis of the affected limb, which is a late sign, altered two-point discrimination, the affected limb feels tense or wooden-like. The pulses in the early phase can be bounding, while in the late phase there can be pulselessness. Pallor of the affected limb occurs in the late course, while rubor occurs in the early course. Polar or poikilothermia involves the limb becoming ice cold, and it is often the same temperature as the environment. And finally, swelling may not be evident. For compartment syndrome, you will often hear about the 6 Ps, which were actually discussed on the previous slide. But the 6 Ps are pain, paresthesias, paralysis, pulses, pallor, and polar or poikilothermia. For labs and diagnostics, you will want to collect a CBC, which may show that the white blood cell count is elevated, a BMP, which may reveal elevated potassium levels, coagulation studies, an electrocardiogram, which can show peak T waves, a UA, which may show myoglobin, creatinine phosphokinases, lactate dehydrogenases. You may see elevated histamine and cytokines. You will want to measure the compartment pressure with a manometer or a slit catheter. The delta pressure is the diastolic pressure minus the compartment pressure. If the difference is less than 30, then you have acute compartment syndrome. Normal compartment pressure is 0 to 8 millimeters of mercury. And then there is also a calculation available to guide treatment. If the tissue perfusion is proportional to the difference between the capillary perfusion pressure and the interstitial pressure, then the calculation is LBF equals PA minus PV over R. The LBF is local blood flow, PA is arterial pressure, PV is venous pressure, and R is local vascular resistance. You will also want to obtain radiographs, ultrasound or Doppler, or even an MRI.
Next, we'll get into the management of compartment syndrome. Compartment syndrome is typically treated surgically, but there are medical therapies and pharmacological therapies that can be used. For example, you can diurese patients to reduce pressure in the compartment. You can use Lasix, or if the body needs to be more alkaline, you can use acetazolamide. And then also pain management is another big thing. Some other non-surgical and non-pharmacological management therapies include not elevating the extremity, because then the blood backflows and then it it just increases pressure within the compartment. You want to remove any bandages or casts or anything that will restrict the limb. Another thing, you want to cut off underlying padding. And then you want to do continuous neurovascular checks to make sure the limb is perfusing properly. And sometimes these patients will require renal replacement therapy. And you want to monitor the intracompartmental pressure continuously. And if the patient has compartment syndrome because of a snake or spider bite, then you want to give the antivenom. And then some surgical management therapies include a fasciotomy. And oftentimes, or sometimes they'll delay closing and they'll put a wound vac. And then also hyperoxygenating has been shown to improve outcomes in patients. You will also see skin grafting procedures. They may need to irrigate and debride the area, And in worst case scenarios, amputation is even necessary. And then sometimes you'll also have restorative management. So you may see functional splinting. Um, you'll see active and passive range of motion exercises. And then if the patient had to be amputated, then you'll need, prosthetic fitting and working on ambulating with a prosthetic. Moving on to interprofessional collaboration of compartment syndrome, you will often have your orthopedic surgeon, the one who does the fasciotomy. You'll often have physical medicine and rehabilitation, especially if someone's been amputated, they need really intense rehab. PTOT for splinting, trying to gain their independence back, mobility, strength. They're involved heavily in with these patients. Wound care will sometimes be needed if they have a wound back or if they had a wound debridement or irrigation. Sometimes a dietitian will be needed to make sure they're getting the proper nutrition in order to heal these wounds and heal these, injuries. And then case management as well is sometimes on board um, because they may have unique discharge needs. And obviously there's other people involved, but those are important ones. Some geriatric considerations to make note of. Oftentimes, compartment syndrome is diagnosed in younger adults, more so than older adults. So sometimes it's missed. So it's important to know signs and symptoms. In the elderly, multimodal pain control is the standard of care. Because these patients often are on other medications, they may be on blood pressure medications, and they don't want to give an opioid and then drop their blood pressure more, um, or they don't metabolize the opioid as well. So multimodals are a big part of managing the elderly. And then aging increases the risk for atypical presentation, so they may present differently than a younger individual. And then the patient's baseline functionality should help guide management decisions. So if the patient comes in, they have compartment syndrome, and they weren't very mobile to begin with, um, then the treatment plan might look different from someone who's coming in with compartment syndrome who was very mobile and active prior. So that's an important thing to note.
For question 1, a 68-year-old postmenopausal woman presents to the clinic after a fall in her home, during which she sustained a wrist fracture. She is concerned about her overall bone health. Which of the following is a major risk factor for fractures in this patient population? A. Regular weight-bearing exercise. B. High calcium intake. C. Postmenopausal status with osteoporosis. Or D. Adequate vitamin D levels and low alcohol consumption. The answer is C. Postmenopausal status with osteoporosis, and that is because one of the major risk factors for fractures is low bone mineral density. Osteoporosis is more common in postmenopausal women due to decreased estrogen levels that affect bone density.
So question 2 says, a 32-year-old patient who presents to the emergency department with unilateral leg swelling, pain, and sensory loss following an injury at a construction site with no past vaccination history should receive which treatment? A. Clindamycin. B. Tetanus toxoid. C. Vancomycin. Or D. Zosyn. The answer was B, a tetanus shot, because the patient got hurt in a construction site, and his vaccination status is unknown.
For question 3, a 35-year-old male presents to the emergency department with severe pain in his left lower leg after a fall from a ladder 6 hours ago. He reports the pain is out of proportion to the injury, worsens with movement, and is unrelieved by analgesics. On examination, the leg is tense and swollen, with diminished sensation and weak dorsalis pedis pulse. Suspecting compartment syndrome, you understand that which of the following best describes the pathophysiology of this condition? A. Increased tissue perfusion due to vasodilation in the affected compartment, causing muscle swelling and nerve compression. B. Elevated intracompartmental pressure that exceeds capillary perfusion pressure, leading to decreased tissue perfusion and ischemia. C. Release of pro-inflammatory cytokines that cause systemic vasodilation and increase capillary permeability. Or D. Sudden rupture of a muscle within the compartment, leading to direct nerve damage and muscle necrosis. The answer is B, because the increased compartment pressure restricts local tissue perfusion by reducing the arteriovenous perfusion gradient and can result in cellular anoxia, leading to nerve and muscle tissue damage. A 22-year-old male presents to the emergency department with severe pain in his right forearm following a crush injury at work 8 hours ago. He describes the pain as severe and out of proportion to the injury, worsened by passive movement. On physical examination, the forearm is swollen, tense, and pale. He reports numbness in his fingers. Which of the following clinical findings would indicate the development of compartment syndrome based on the 6 Ps? A. Pain, pallor, pulselessness, paresthesia, paralysis, and poikilothermia. B. Pain, pallor, pulsations, parasympathetic activation, paralysis, and pitting edema. C. Pain, pulse intact, paresthesia, pallor, pressure, and polydipsia. Or D. Pain, pulsations, polyuria, paresthesia, pallor, and poikilothermia. The answer is A, and that is because the 6 Ps include pain, pallor, pulselessness, paresthesia, paralysis, and poikilothermia.
Lastly, question 5. A 28-year-old patient has sustained a right tibial fracture. In the emergency department, the patient notes a new onset of pain that is a 10 out of 10, decreased sensation in the right lower extremity, and the extremity is also pale. Which of these diagnoses is best supported from this patient history? A. Compartment syndrome, B. DVT, C. Peripheral artery disease, or D. A fat embolus. The answer was A. Compartment syndrome, because the patient is experiencing some of the 6 Ps, which are pain, pallor, pulselessness, paresthesia, paralysis, or polar, thus making compartment syndrome an appropriate diagnosis.